Good evening and welcome to the Monday Agenda. The Monday Agenda today, once again, as we did last week, is at Repoa to finish the series of the survey that was conducted. Last week we looked onto the education, but today we are looking onto the health sector, and we are looking onto how the health sector delivery environment and performance is enhanced here in Tanzania. And with me, once again, I'm honored to have this interview with Dr. Lucas from Repoa. Dr. Lucas, karibu sana.
Asante sana.
Let us go straight into our topic, but for those viewers of the Monday Agenda who did not or were not able to join us last week, probably you want to bring us slightly back onto the introduction of the survey that was conducted and the objective of the survey.
Yeah, thank you very much. Actually, this survey was conducted jointly by Repoa and the World Bank. And on the government side, you have the Ministry of Education and Ministry of Health.
Very good.
The purpose of the survey was to find out the outcome of learning and the outcome of service delivery. We are looking into three aspects. One is on the providers, is on the input. And in the health sector, we are specifically looking into the drugs availability and the infrastructure. And in the second item that we are looking for is the providers' efforts. Mm-hmm. I mean, what time do the providers use to actually do what they are supposed to do? Like if it's the doctors, nurses, are they available for patients at the time that they are required to be at the health facilities?
Okay.
And then we look into the provider's ability. Yeah, the one aspect is to have someone at the office working, but the other aspect is to see whether they are able to deliver the required services.
Correct.
So these are the three aspects that we have been looking for the survey.
Okay.
And we are doing it now we have just done it for the third time in the year 2018-19. And the other two surveys preceding the last one were done. One was a pilot in 2010, okay, which was done in Tanzania and Senegal. And the second one was the follow-up survey, which was done in 2014. And this one was done in 5 countries, okay, Tanzania, Uganda, Kenya, Senegal, and Nigeria.
Okay.
Yes.
So last week we focused mainly, Doctor, on education, and we exhausted,
Absolutely,
although the 45 minutes of the Monday Agenda can never be enough to exhaust the challenges in the education sector.
Absolutely.
And we have now another 45 minutes to look onto the health sector. To as far as the 3 dimensions that you've mentioned, Doctor, whichever first one you want to start with.
Yeah, maybe I should first give the context on the importance of the health sector.
Very important.
Yeah, actually, investment in human capital is very important. And there is close correlation between investment in the human capital and economic growth and development. So if you look into those countries that have invested a lot in human capital, are also the ones that are experiencing high growth rate, but also human capital development is quite high. Mm-hmm. And Tanzania as a country also recognizes the importance of investing in the human capital. Okay. You can see actually the resources that are devoted into the health sector, for instance. In absolute term, the budget has been increasing over time. I cannot provide the figures, but if you look at the budget figures over time, it has been...
In the health sector,
exactly,
particularly, yes.
Yes, it has been increasing over time, particularly in the last 10 years. But then the challenge has been on the percentage of the budget that is devoted in the health sector in relation to the national budget.
Okay, all right, that is interesting.
Yeah, that one has gone down. For the year 2013-14, it was about 10% of the national budget went to the health sector. But in the financial year 2019-2020, it had gone down to 6%.
Wow.
Which is significant, actually. Although in absolute term, the budget has increased. But then as a percentage of the national budget, it has gone down.
Okay.
And of course, this is the shortfall of the Abuja Agreement, okay, which required all countries to ensure that the budget devoted to the health sector is at least 15%. So you can see that we have a shortfall, significant shortfall, okay, of Abuja Declaration. Yeah, but then in that case, there are a number of challenges that country is facing. A number of health providers, number of facilities to meet its growing demand, especially as the population increases. But also we have inequality between urban and rural, but also between private and public health facilities.
Okay.
So because of these challenges, the World Bank and the Repoa, together with the Ministry of Finance, had to conduct this survey to see what are really the problems and what can be done to improve the outcome of the health sector. So that's when we focused on the 3 dimensions. So maybe I should start.
But before you go to that, Doctor,
Yes.
You've mentioned a very pertinent issue of the differences between what is actually allotted as the budget for health and what is apportioned to go onto the health service directly. Is it probably because Doctor, people are not getting sick? Probably demand has declined. That is why the resources are not so much allocated into provision of health services.
Basically, as I said
Oh,
before,
that is what you're going to find out from the
yes,
from the study.
but then in a nutshell is that in the absolute term,
Yes.
the budget has been increasing. It's only the share of the budget when you compare to. This means that there were other sectors that we are getting less and less. Now they are getting more and more.
Okay.
Probably as you look at the country's recent approach of increasing infrastructure, it's very possible that the biggest share that has gone to infrastructure has resulted into the share of the budget to look as a small, although in absolute term it's big.
All right. Correct, Doctor. You're welcome.
Yeah, okay, let's look into, I mean, there are various 3 dimensions I mentioned. Let's look into the inputs. Inputs, basically, we are looking into the availability of drugs. And when we're talking about drugs, it's not like all the drugs that should be available in the hospitals. We actually assessed into 14, we call them 14 tracer drugs. These are basic drugs that are commonly used and they are frequently used in the health facilities.
Okay.
They have to do with under 5 mortality rate, maternal mortality rate, acute diarrhea, pneumonia, malaria. Those are the drugs that are commonly used. So 14 drugs. If you look into the, if you look into the directory for the health practitioners, they will identify those important drugs. Okay. So 14 of them, those are the ones that we have made the assessment. And if you look into the availability, the situation is fairly good because actually about 67% of those type of drugs were available. 67%.
Okay, all right.
Were
not
available.
So good, but it's okay.
Yeah, not so
above
good,
average.
but it's above average, exactly.
Yeah.
Of course, also when you compare to other countries that have done similar survey, you realize that somehow we are fairly better, not very much from other countries, but relatively better. And if you look at on its own, of course, 67%, it's a good, relatively a fairly good performance. And of course, there are challenges between this inequality between rural and urban. Okay. The urban is doing very well compared to rural, which is a bit of a challenge again in the aspect of ensuring that citizens are getting a health facility as much as possible because majority of Tanzanians are living in rural areas. Okay. So there's a kind of inequality between the supply of these drugs between urban and rural. Rural are consistently in significant worse when we compare to urban areas. Okay. Yeah. And then within the same context, the same aspect of inputs, we are looking into the infrastructure. Okay. And in the infrastructure, we are looking into 3 elements: availability of electricity, clean water, and the good sanitation. Okay.
Maybe before we go to infrastructure,
yes.
Dr. Lucas,
yes.
One of the lessons I learned last week when we were discussing education is that the fact that the students do not have textbooks in classes, but they have textbooks in the libraries, for instance, or in the staff rooms. Is it not similar case when it comes to
the drugs?
Yeah, the drugs.
No,
they were not in the facilities completely,
exactly.
or they were not, sort of like they are ready for disbursement when
no,
the
actually they were
them.
not. For the case of availability of drugs, yes. We actually assessed the stores.
Okay.
Of the,
so they are not in stock.
They are not in the stock. Okay. Unlike in the education, you look into whether they actually whether the pupils are using the books. Yes. And then you look into the store, books availability, but
they're not used.
Yeah,
in the
but
classes.
then in this case, we're actually looking into the stocks availability, assess the logbook on the amount of drugs they received, and it look into whether those drugs are actually available in the stores or not. Okay. And we actually see that we had this 67% availability. And then in terms of infrastructure, I mentioned that we were looking into three aspects. One is electricity, and then two is water and sanitation. And of course, we see that about 62% of the health facilities had the minimum required infrastructure.
Okay.
Yeah, again, this is not very bad, but of course, again, another challenge was on the levels, availability and levels. You see that the levels, the adequacy of this infrastructure were better in the higher level than in lower levels. For instance, about 46% of dispensaries, only 46% of dispensaries had the minimum required infrastructure. And then when you go to higher level, which is a health center, 78% of the health centers had minimum infrastructure.
Which is good.
Exactly. But when you go further to the district hospitals, 85% had required infrastructure. So again, you see that on the average is 62, but then the lower level infrastructure are the ones that do not have the minimum required infrastructure. Again, this is a challenge because, of course, majority of the citizens are saved
accessing those facilities.
In those lower facilities because they are the ones that are close to citizens.
Okay. Again, my question related to exactly that, Doctor. As you move up,
yes.
So it looks like the focus has gone more towards, advanced facilities from the district level going up. From the ward level going up. That's where there are improvements.
The improvement you are seeing, yes. But then partly it might be structurally that to be the case because one for instance, it's in recent years that we see the government now devoting efforts to ensure that every village has electricity. But it was quite common, like 14% of the population were only access to electricity, 18% up to the last household budget survey, which was conducted in 17-18. So you see that it's possible that because of the location of these facilities and the coverage of electricity itself, automatically those that are in the rural areas were missing this facility. But as we move forward and with the government efforts to ensure that all the villages are having electricity having water, then probably if we conduct another survey now or in a year or two, probably you can have.
We're looking onto what sample size, Doctor? We're looking onto
400 health facilities
in the country.
And then they are well represented, and we ensured that we can do the disaggregation of data in line with the national surveys, that we have urban areas and rural. But of course, again, urban areas, we are looking to the slum as a specific urban area. So we can do the slum, other urban areas, and rural areas. And these are the disaggregation of most of the national surveys that are done by the National Bureau of Statistics.
So when you say 67, 82, these are out of the 400?
Out of the 400. But then when I say 46% of the dispensaries are the only that have minimum infrastructure, then I'm talking of the dispensaries only. The 46% of the dispensaries only.
Out of the dispensaries out of the 400.
No, 400 facilities.
Is in total dispensaries,
and
hospitals.
Exactly. Then they are distributed according to their proportion. So if we have 60% of the facilities are dispensaries, then out of the 400, 60% is dispensaries. And so on and so forth.
All right, understood. Let's proceed, Doctor.
Okay, so that's so you can see that challenge. But again, when you look into the private and public, again, private facilities are doing better than public facilities in the infrastructure. And then an interesting part again is that the urban councils are doing better than rural councils. Of course, we have seen that the infrastructure, the minimum infrastructure are better as you move up the ladder. But of course, if you look at the urban and rural, actually the dispensaries in urban areas are doing better than health centers in rural areas. Although health centers are at the higher level than. So you can see this inequality. And then the second aspect that we have been looking is the providers' effort. What are the providers do? The workload, we are looking at the caseload. Caseload is the average number of patients per day per health officer. So it has been a song that is sung by many countries, by many practitioners, development practitioners, that in developing countries, the caseload is quite high. But the survey do not seem to suggest that direction. It looks like in Tanzania, the caseload is not that much high.
Okay, right.
Because the average caseload in Tanzania is about 8%, 8 people, 8
people.
patients,
Okay.
outpatient.
Okay.
So 8 outpatients are, on average, are saved by 1 health officer, which is relatively better than even neighboring countries.
Is this in the urban setting or in
No,
the
no,
rural
in the
setting?
average,
generally?
average,
Okay,
average. No, I'm coming
average.
into that disaggregation again.
All right.
So if that is the average, but then if you look into the disaggregation, you realize that, again, by levels, majority, as I said before, are saved at the lower level health facilities.
Correct.
Like on average, it's about 13 patients per health officer in the dispensary compared to about 4 in the district hospitals.
Okay.
So again, you see that the lower cadres are saving majority of the citizens compared to the higher cadre hospitals. Yeah, that's the thing that we have seen. But again, an interesting feature is that we have, while another thing that we looked in, not only the caseload, but also on the absenteeism rate.
Okay.
Again, in the absenteeism rate of health facilities, that's where we get interesting finding. We find that Tanzania is still doing better than other countries.
Okay.
On average, it's 16% absenteeism rate.
16%, okay.
The other side of challenge is that this level has been increasing over time. Although, while we are doing better, but then the absenteeism rate has increased over time.
Okay.
And it increased, it was 14 in 2014. And then currently survey, which was 2017-18, it's
gone up
16, 2 percentage point increase. It's insignificant, but it's something that one need to check because the severity of it will have an adverse impact on the outcome of health. Yeah, but then the thing again is that when you look into the cadre of those who were absent and then distribution, then disaggregating between rural and urban, actually you see that doctors are more absent than nurses and the other clinical officers, which are in the lower cadre. Doctors seem to be more absent.
Yeah, they're very mobile.
Exactly, that's one. And then you also see that the absenteeism rate, while in urban areas actually, they are also more absent than in rural areas.
Okay.
Yeah, and in the slum is even serious because 25% absenteeism rate is 25%. So this might say that maybe because of the opportunities, number of hospitals available in the slum, the flexibility,
fewer members in the health sector.
I mean, you have many health facilities that doctor can be absent and get another facility to work on.
Correct.
Yeah,
that's why I said we have many health facilities, but we have few doctors with such an experience.
So in rural areas, actually, it might be difficult because then moving from one health facility to go and save another, it might be a challenge. So that may explain why in rural areas, absenteeism rate is not serious as it is in urban areas. And of course, the doctors are more absent than other. It also says that they are flexible.
I'm coming, Doctor, to the aspect of absenteeism and the commitment, but I want to take you slightly back.
Yes.
Recently, about 2 or 3 months ago, I was listening to His Excellency Dr. Mwinyi, the President of the People's Republic Revolutionary Government of Zanzibar.
Yes.
He said when he was concluding his mission, visiting the regions in Zanzibar, he said on the health sector specifically that, you know, the procurement of drugs, for instance, medical equipment, etc., is the one that takes longer time. I'm not sure now when you mentioned on the import to the medical requirement necessities, the drugs and the medical equipment, etc., if that was also one of the factors that was seen. I'm not sure in the 400 we also have included Zanzibar, this was mainly on the mainland. But I wish to know in the input sector if delays or challenges in the procurement, challenges in the, you know, the requests for medicine and they're not made available in time in the health facilities, maybe that's when they clashed with the survey.
I'm not sure. Actually, Zanzibar was not part of this survey.
Zanzibar was
but
not,
of course, the challenge that are happening in Zanzibar could also be the same
Similar
challenges
here, yeah.
happening in Tanzania. So I can't comment on that in terms from the survey, but of course, from my own opinion, it might also be the challenge that is facing Tanzania. There are a lot of administrative procedures that one has to follow before signing of the documents, approval processes, before the procurement can be actually undertaken. So that could be the case. But I think that also can be solved by ensuring that for important, the importance of drugs cannot be waiting for someone is sick, then they have to get the drugs on time. So I think you have to ensure that you create a mechanism that can speed up the process for those procurements that are urgent, that are needed urgent at their use point.
And these are hardly 14, as you mentioned earlier.
I just mentioned 14 drugs.
Yeah.
So it's important to ensure that, look into the procurement processes and of course look into the user units, the importance of the procurement, and then try to find out the mechanism which can speed up those procurements that will have adverse impact if they delay to be delivered, and drug should be one of those.
On the same note, Doctor, Dr. Lucas, you've mentioned specifically on the drugs. Yeah. What about the medical equipment? The likes of, the equipment themselves, the physical equipment.
Yeah, I should have mentioned that actually.
Yes.
We also investigated some of the equipments, like availability of
microscope, for instance.
Exact microscope, and this were available. But then we were looking into some aspects like what are these? We call these vaccinations, which are very important for for children and five. Yeah. And they were fairly available. The only challenge was on the equipment, because these vaccinations have to be stored at the fridge, and there is a minimum temperature requirement of the fridge. So it was quite clear that some of the fridge, actually most of the fridge, didn't meet the minimum required temperature to keep them at the standard. So that is another challenge whereby one can access, people can get vaccinated, but then the vaccinated does not meet the standard. And this again was a challenge, particularly in rural areas where the electrification system, the coverage of the electrification is low. So equipment might be available, but then of course
they do not have electricity, so they can't function.
Yeah, they have the way they can use some kerosene and whatever, but there are challenges associated to the minimum temperature requirement to ensure that the vaccination is of the standard. So that was a challenge that was seen particularly in rural areas.
Wow. Okay. I'm afraid, Doctor, personally to ask about the risk of that, but please let's proceed.
Yeah, of course, that can be done by more. I am not part of the health. I'm not practitioner.
Of course.
Yeah, so just looking into those aspects of the access, it is about access, quality and whatever, but then I think you can talk more with the people who are practicing, actually the health specialists. They can tell you the implication of that.
Wow.
Yeah.
Okay.
Yeah. Okay.
Absenteeism, you did mention that, Doctor, but that's exactly where we had ended. But I really beg to also understand that the ministry, is aware. I will bring this similar situation to last week's discussion when we discussed education. And we looked onto the aspect of teachers being there but not attending to classes, or teachers not being there, and relating it, of course, education and health. These are sensitive, but health is more sensitive because it demands attention there and then when needed. But it's a substantial amount.
16 is not something that you have to be happy with.
Yes.
Yeah, because then you are talking about 16% of the patients coming there without getting services at their right time, which has implications in terms of the severity of diseases, but also the time that they could leave and go to do other activities is also jeopardized. So it's not something to be happy with. It's minimal compared to other countries.
The fact that it is increasing, that is for me raising a red flag, like, please note this, from 14 to 16.
Yes.
Yeah, 2%. We do not know when you are going to do the next survey to get that another signal.
Yeah, we are.
What were the main, probably one or two, Doctor, challenges for that increment?
In
from
the
14 to
absenteeism.
16, yeah.
Yeah, I think it's about the moonlighting activities, but also it could be associated with the incentives.
Okay.
Yeah, maybe I think addressing some of the incentive challenges and also increase penalties to those who are, you can penalize someone if you can fulfill their obligations, ensuring that they have enough income to meet their minimum expenditure, send their children to school, having enough food, shelter, and then impose the penalty and the sanctions. So it's possible that improvement in the inspection and of course the incentive package as well can also address these challenges.
Okay. You are watching the Monday Agenda, and the Monday Agenda today is looking onto the healthcare delivery environment and performance in Tanzania, a survey that was conducted by Repoa'S, commissioned by the World Bank, and of course from the government side, the Ministry of Health. And we're looking onto how the health sector is responding in relation to the input, in relation to the budget that is allocated to the sector, and what are the challenges and how can we address, at least know those challenges so that different interventions can come in and address those challenges. We've looked onto the issues of input, we've exhausted it, although we can't again exhaust it. We've looked onto the issues of human resources, and we're looking onto how medical cadre is absent when the services are required. And with me on the program is Dr. Lucas, who has championed this study. Dr. Lucas, please proceed.
Yeah, now let's look into the third aspect, which is ability. To what extent are the service providers able to deliver the required services?
Okay.
And we are looking into we are looking into four, actually. We call them, it's about 4 tracer cases, which are quite common cases. And these are pulmonary tuberculosis, pneumonia, diabetes, and the malaria, and the acute diarrhea. So these are the 5 common cases that are usually, whose incidences are higher.
Wow.
So we looked into those 5 cases and the extent to which the medical practitioner can correctly diagnose them and provide the right treatment. But also looked into the extent to which the health practitioners can handle complications in the newborn. So these are the common cases that they will definitely face as they treat patients. So they were looked into to what extent are they understanding ABC of delivering these services.
Okay, I'm interested on that, doctor.
Yeah, it's very interesting. And then the results show that, the results are very interesting. Because basically what we see is that about 62% of those cases were correctly diagnosed by the health practitioner.
62% is a good number, but still not very good.
Not very good, yeah. So again, there are differences between urban and rural. Urban areas, they are doing better in providing the correct diagnosis of those 5 cases compared to rural areas. So that is quite clear. But also there are differences between the cases itself. Some of the cases some of the health practitioners seem to be very conversant to some cases than others. For instance, pulmonary TB, about 91% of the health practitioners were quite able to provide correct diagnosis for the tuberculosis.
91%, that's revolutionary.
And then you have again, you have pneumonia, 75% of the health practitioners were able to provide correct diagnosis for those diseases. And the weak part was on the acute diarrhea, where only 44% of the practitioners were able to provide correct diagnosis of the diarrhea. And this was followed by about 50%, which was malaria. So again, the interest side of this is that Tanzania, of course, apparently we have been able to address, to do with malaria to a large extent. But of course, it's challenging that you have about 50% of the health.
I'm shocked. Literally, doctor, you should see the expression of the face. But we've had malaria for, God knows
so
how
many
long.
years.
We still are at 50%.
of the 50% of the health practitioners that can
Yes,
provide
I'm saying
correct.
we're still at 50%.
Yes.
Whereby malaria should have probably been a case study as you study medicine in Tanzania.
I mean, it should have been like 100% of those.
Of course, yeah, that's what I was hoping and
providing
thinking.
the right diagnosis.
Yes.
So I don't know why. Maybe probably because now it's going down, the attention may have gone to other diseases that are like non-communicable diseases, which are now mushrooming. So probably moving the attention to other diseases may have actually jeopardized the expertise in this area. But I still think that we needed to improve in malaria because still it's a problem. So again, that kind of differences between urban and rural, but also between different practitioners. Also, it's different cases. It's something that is of interest, and the government may, and the other health stakeholders may actually use the result to see how to improve their capacity building, on-job training, in order to ensure that all cases are getting equal capacity in dealing with them. Yeah.
Okay. Where, doctor, do you reckon then we go wrong? Where do you reckon we go wrong as far as service delivery? From the findings, of course. Not from, from the findings. Where do you reckon that, the health sector or the Ministry of Health should look keenly on 1, 2, 3, 4 from the findings?
What I'm saying is that I have no problem with the training institutions.
Okay.
But of course, I think the challenge is likely to have happened in the on-job training.
Okay.
Yeah, the world is running very fast. And because of the movement of people from place to place, even new diseases are coming. Okay. And then all the ones are disappearing. And as the result, it's important that you probably have studied something that is disappearing now. Okay. And you have to learn on new things that are coming. So it's important to ensure that we have this on-job training as part of the regular activities of the ministries and part of the training plan of the Ministry of Health and the health practitioners to be able to move, to have the speed that the world is moving with.
Of course.
So that might be the challenge. And of course, there are things around incentive also. That, of course, there are common saying, which is quite common in the debates and discussions, that udaktari ni wito.
Okay.
Yes,
of course.
it is definitely, because then you have to do, you remember about 2 weeks ago, someone had treated someone who had got an accident, and then because they didn't have 10,000 shillings, she had to redo everything, he had to do everything he had done. So everybody was worried that life of person, you shouldn't compare it with 10,000 shillings. So the fact that he didn't have that money, shouldn't have reached into that extent. Yes. So the tendency is to say, but then when you go to a marketplace, a seller of something, you have money, you get it, you don't have money, you don't get it. So that's why they say udaktari ni wito. But of course, but of course you have to look at it very carefully, because the doctor also has obligations. He has the family to take care of. He has the family to ensure they have education, they have health, they have food, shelter, and every other thing. So it's important to ensure that the incentive system is in a way that, despite of the saying that it's wito, but also they can cover necessary minimum life requirements to enable them to move forward. So it's important to address issues around that.
Dr. Lucas Katera, a lot. I must commend, you've mentioned for the past 10 years, but I must commend the 5th and the 6th regime to have, injected a lot of resources in the medical sector. Exactly. But doctor, if you look onto the trends, I may not specifically have the numbers, but the medical sector is somewhat in the decline in terms of, we've looked onto the service, but I think more people, turnaround time for the services, I think more people get ill now, other than, of course, COVID, which is, coexisting amongst us. Yeah. But, I think we have more patients now than it used to be in the past. Yes. Irrespective of the investment that the governments are putting into the budget. What does the survey have to say about that?
Yeah, of course, the challenge is that the incidences of getting ill is increasing in terms of numbers, but then in terms of percentage, it's actually going down. If you look into the percentage of the people under 5 mortality rate, for instance, it used to be too high.
Doctor, please say slowly. What is increasing, but say that again
what
slowly.
I'm trying to say is that the number of people who are getting ill for a particular episode of disease is increasing. Of course, because the population is also increasing very fast.
Yeah.
But then if you look at that number as a percentage of the population, it's actually going down.
Okay.
Yeah, so it's, I mean, you could also say clearly that there are developments that are made to ensure that the percentage is going down, although the absolute number is increasing because the population is increasing.
Okay.
So what I'm trying to say is that there has been development in the health sector which have been able to address the challenges in the health sector. But the challenge is that the speed in which development in the health sector are made against the population is a challenge. I mean, we have to invest more in the health sector than we are currently doing because the population is, the demand for health sector is increasing at the faster rate than it was in the past.
Okay.
So you have development, but then it's getting challenged because the problem itself is increasing fast because of the increasing population, urbanization. I mean, environmental degradation is quite high. So all these are contributing to health hazards. So it's important that investment is also increasing in the faster speed than it is. You pointed it clearly that there are a lot of investment, and I believe that if we are going to do the similar survey today, we may have different because results. The number of, for instance, the number of dispensaries that have been built in the last 2 years are quite many. Yeah. The health facility, health centers are quite many. Hospitals that have transformed from health center to district hospital, referral hospital, have also increased. So maybe the other survey, which is planned perhaps next year, if we are going to have enough fund, we are planning for this survey next year. So if we are doing it, probably we shall get more updated information about what is currently happening.
We look forward, and we'll certainly be there to cover, and the Monday agenda will once again be delighted, to see this progression. I look forward to really hoping that it's going to be some positive.
I also hope that we are likely to have some positive, but of course there are challenges that are coming, like COVID may also jeopardize some of the health outcomes. For instance, I believe that the resources that are devoted to the health sector, although it's increasing, but of course if it decreases from other components within the health sector, it may also have effects on that sector. For instance, if the money that was to be directed to maternal mortality health has gone down because the disaster of the COVID is quite high. On the average, the health sector will have increased budget, but then some components are going down, therefore affecting the outcome. So, I mean, there could be mixed results depending on the world development, which is not specific for Tanzania. It's something that is happening to many other countries of the world.
I'm not sure how lengthy or well spread the survey went in terms of, you've repeated mentioning that Tanzania's population has been increasing. I want to know, Doctor, and if you have this information, normally standards are set by some, organization that sets standards worldwide. But if you look onto the population of Tanzania, which is approximately
close to 60 million.
Close to 60 million. How are we faring in terms of the available facilities vis-a-vis the population? And then I will go probably to these facilities, the population, and the medical practitioners. The ratio. Are we doing not very good, of course. Are we doing better?
No, actually, partly yes, partly no. The challenge is, I mean, as you put it correctly, the population is increasing very fast. And we have to increase at the same rate everything else. The demand for Tanzania, the demand for all other development sectors is quite high. We need to invest in manufacturing so that people who are graduating from school can get employment. We need to ensure that we have infrastructure so that we formalize informal sector. The rural people can be exposed to urban areas and so on and so forth. So the demand is quite high everywhere. But then the resources are limited.
But so, how are we faring as a country now Do we have facilities sufficient to meet the demands of the country?
No, we can't have. Apparently, we don't have that facility to meet, because actually, on average, everybody has to walk about, I think, maximum 5 kilometers to get the health facilities.
Okay.
Yeah, but on average, we might be close to that on average. But then when you look into the inequality between urban and rural is quite high. In some of the rural locations, people have to move 10, 20 kilometers to get the health facilities. In urban areas and in some other developed parts of the country, you just move like less than 500 meters, you're in the health facility. So the average might be good, but inequality has to be addressed because it's a challenge. Really, some of the rural areas, Tanzania. Tanzania is a very big country, and the population is quite sparse. Everywhere you find settlements. So it's not easy that everybody at any point can get the health facilities within 5 kilometers.
So 5 kilometers is a normal given standard?
Is the average. Is the ideal standard,
ideal
maximum.
Standard.
Yeah, because then we are sure that, but of course 5 kilometers, there should be also the easiest way to get into. Because you may have 5 kilometers.
Proximity.
Yeah, 5 kilometers, but then the road to get the 5 kilometers takes years. So it's important, it's 5 kilometers, but there should be an easy way to get into the facility. So which is a challenge in many parts of the rural areas.
We're going very close to the end of the Monday agenda, sadly, again, because I still have a lot of questions. But you've done this survey with the Ministry of Health, commissioned by the World Bank. And the Ministry of Health has been part and parcel of the process and the entire study. So they have these findings. Should we start looking on to some of the positive responses as we anticipate the findings from the next study, that they've taken these findings and they're working on them to address the issues of absenteeism, to address the issues of input, to address the issues of the 14 drugs, improved skills from on-job trainings, etc. Should we look forward to that?
Yeah, at least some of the things we can see them happening, like the availability of the not the drugs, but because that one we haven't done. But then at least we can see that the facilities themselves are increasing very fast. And of course we know that, again, the government is looking forward to have all the villages covered by electricity in the next few years. And that will improve on the infrastructure. Also, there are a lot of efforts that are made by the Ministry of Health to ensure that water is available everywhere. So this will also improve. And we can see that positive trend. And so we actually have a feeling that the findings of our studies are taken on board. Of course, there are limitations beyond which the government can take them on board, because then they have to take that on board within the budget availability.
Of course, and the development framework.
Yeah.
Doctor, we've come to the end of the program, but I would like to give you a minute to say anything else about, specifically on the survey, but on health.
Yeah, exactly. I said before that there are areas, the improvement on the shortcomings that have come from this survey can be addressed to some extent without investing a lot, without having a budget set for that. For instance, inspection. You can improve inspection system so that the absenteeism rate goes down. And this doesn't require a very big budget investment on that. So the government can invest on that. But also the issues around the awareness. So citizens should, there should be civil education to improve awareness of the citizens on their rights to get treatment, reporting cases. So if they see the doctor who is allocated in their area is doing different things at the time when they should be at the health facilities, they should be able to report that. So civil education is important for the people to understand that they have right to provide that information without any penalty against them. But of course, I said before, issues around incentive, improvement of the incentives so that they are happy to work, and improve sanctions around that. It can work on job training to improve their skills as the world is changing, new diseases are coming, all diseases are going. So it's important to have on-job training. I think this year, some of the few aspects that the government can devote just some additional budget and then address this huge challenge.
Well, my dear viewers of the Monday Agenda, I would also like to end the Monday Agenda today with the very first, just the first line from this extract of the survey on health report that says good health is indispensable towards promoting the well-being of people as well as the nation's development. And this was marked by the World Bank report of the year 2016. Good health is indispensable. They say you watch your health, you eat healthy before, medicine becomes your eating habit.
Yeah.
It becomes part and parcel of you.
Of your food.
So let's really put into consideration the aspects that Dr. Lucas Katera has mentioned, that we really need to look and focus on to first our own well-being, looking on to what we do, how we do in relation to our health, so that we can lead healthy lives and keep away the hospitals. There are countries like Korea, I think, that has been able to reduce the number of hospitals and just letting people live and lead healthy lives. It can be done in Tanzania. Let's help the health sectors to actually be able to provide good services by improving our civil education, so that people can report any misconduct of such sort, so that the medical cadre, the medical sector really takes positive strides here in Tanzania. With those few remarks, allow me once again to thank you, Dr. Lucas Katera, for this wonderful session we've had. The health sector and the education sector, personally, I take them at heart, and I believe that the two ministries that have participated in the study will take seriously the findings towards improving service provision in these two sectors. With these few remarks, thank you so much for watching the Monday Agenda. I'm your host, Austin Makani. Until next time, stay tuned.